I knew I wanted to go into surgery. I was always interested in physical, hands-on kind of medicine. And then as I got to see neurosurgery and understand it in my second and third year medical school, I decided that would make a natural fit. My work is completely inside the head and neck, and it's all having to do with abnormalities of blood vessels in the head and neck. And specifically, in this situation, brain aneurysms, which, although we say brain aneurysm, it's really a vessel aneurysm. This is a weakening of the vessel wall. It's an outpouching, it's really a bubble. And the problem isn't that people have them, because a lot of people have them. It turns out if you look at autopsy studies, 2 to 4% of the population can have what you call an aneurysm. We've come up with the number of 1 in 50 for people to carry in their heads so they know the prevalence of the disease. But the problem comes when these things rupture. That's when catastrophe can strike, which happens in a split second. And the aneurysm bleeds just for a fraction of a second, and then it seals itself off in many people, not in everyone. Unfortunately, about 20% of people die at the time of hemorrhage. Because if you think about it, 1 in 50, that means if you're sitting on a bus with 100 people, 2 people on that bus have an aneurysm. Now, not all those go on to hemorrhage. Our quest now is thinking about who should we screen. So at present time, the current recommendations for screening are in a familial situation. About 25% of aneurysms run in families. And when they do run in families, that is 2 or more blood relatives, we recommend screening for the rest of the family. But that's still only a small part of the population. So there are patients who are more at risk of developing brain aneurysms than less. For unruptured patients, almost every study that's been done, 2/3 of the patients are women. So it seems to be more prevalent in women, at least unruptured aneurysms. Ruptured aneurysms, still more prevalent in women, but a little less so. It's more like 60-40. Another big issue is smoking. Smoking and aneurysms. It has not been proven yet that it's cause and effect, just like lung cancer. It's hard to prove it. We surveyed about 2,000 of my patients, and 80% of the brain aneurysm patients we had seen either were in the past or were at the time of diagnosis heavy smokers. At the Brain Aneurysm Foundation, we now have actions in place to look into the medical school curriculums to be sure this is being covered. As you know, information is exploding, so it's hard to keep track of all this. But the point is there are many, many stories of people, not just with a nagging headache, but the worst headache they've ever had. They seek help, or sometimes don't, but when they do seek help, if the person seeing them, the nurse practitioner or the physician, doesn't think about the diagnosis of an aneurysm, they won't proceed to make the diagnosis and treat the patient. And that's the time to intervene when the patient has just a headache, because there's a lot of data that shows the better a patient is at the time of hemorrhage, the more likely they are to do well. So aneurysms can be treated in a couple of different ways. One is to actually open the head, to make an incision, remove a small piece of bone, and go in and clip off the aneurysm or seal it off. And I spend a lot of time doing that. The other way we treat aneurysms is to actually go inside the vessel, or so-called endovascular. And we can actually usually go up from the groin or the arm and take a small catheter. And then there are a number of treatments we can do inside the artery to seal the aneurysm off from the inside. And I spend a lot of time doing that as well. So I do both procedures, both types of procedures, and within each type there's a number of maneuvers that can be done to cure or treat an aneurysm. Both techniques, and used together, you pick the best procedure for a given aneurysm. We just completed a study showing that the risks of treatment are falling significantly when you use that strategy. As opposed to only doing one procedure, not every aneurysm is fit for each procedure. And so by using both procedures, you can actually drop the overall risk of treatment.